Professor Christopher McDermott is the lead head for the bacterial and parasitic infections theme at the Doherty Institute. Chris obtained his PhD in microbiology and biochemistry from the University of Queensland. In 2018, he set up his laboratory of the Department of Microbiology and Ecology at the University of Melbourne at the Peter Doherty Institute for Infection and Immunity. In 2022, Professor McDermott was awarded a competitive Victorian Research Acceleration Fund grant to further his research into breaking bacterial resistance to antibiotics in the treatment of sepsis. Sepsis is the body's overwhelming inflammatory response to infection that is not treated properly, can lead to tissue damage, organ failure, and death. In Australia, there are 55,000 sepsis cases every year, resulting in more than 8,000 deaths. Sepsis remains the leading cause of death in hospital. The rise in drug-resistant bacteria is complicating traditional treatment approaches for sepsis. Use of ineffective antibacterial complicates treatment by missing or delaying the delivery of effective therapeutics. Chris's project through the VMRAF hopes to address this problem by identifying ways we can effectively treat sepsis again using frontline antibiotics. Chris will now update us on this very important project, along with symptoms, actions in response to the symptoms, and the latest in research around this very serious disease. So please welcome Professor Chris McDermott.
Thank you for that introduction, Sue. So, as Sue mentioned, look, I'm an academic researcher at the Doherty Institute. And so when invited to speak, I did prepare this talk in somewhat of an academic style. So I apologize if this comes across a bit like a lecture. So don't worry too much about the text on the slides. I'll lead you through everything. And I can guarantee there's no test at the end. So you can ask me questions instead of the other way around. So look, today I've been asked to really speak about sepsis. That's a condition that kills more people worldwide than cancer, and really what we're doing in the lab to try and fight back. So probably best to start with what is sepsis? Well, sepsis is really a life-threatening emergency that occurs when your body's own immune system essentially overreacts to an infection that leads to damage of your own tissues and organs. So essentially, it's what happens when your immune response goes out of control. So really, it starts normally with an infection, really any type of infection, a chest infection, a urinary tract infection, or even a cut. Now, normally, if you get, say, a cut that gets infected, what you can see is that, in response to that, that cut will get red and swollen. And that's part of your body working as it should, that normal response to try and control the bacteria. And that's, unfortunately, what happens, though, in the context of sepsis, there's this red and swollen nature, or this immune response essentially gets out of control. Instead of just fighting off that infection, the immune system starts to cause damage to your own tissues and organs. And essentially, you can think of it a bit like friendly fire, where the system that's there to try and protect you against an invader is actually causing damage to systems that you don't want it to. So in sepsis, this inflammatory response essentially starts to spiral out of control, and this leads to damage of blood vessels and organs. And ultimately, this is what can start to cause organs to shut down and lead to potential death. So it's really important to point out, at this point, that sepsis really starts with what's really quite a mild infection to begin with, and can escalate very rapidly, going from this mild illness to a life-threatening infection within a matter of a few hours. And so this is really why it's important to understand what sepsis is and why awareness of this condition really matters so much. So I think that can be highlighted really by the global impact of sepsis. I've heard in some conversations with members in this room just how much sepsis has touched various people's lives. In fact, that's because it's one of the leading causes of death worldwide. So according to recent data, there are about 166 million cases of sepsis worldwide every year. So to put that in context, that's about 6 times the population of Australia every single year who come down with sepsis. Of those, about 21 million people die, and that makes sepsis one of the biggest killers on the planet. And so to put all that together, really what we're seeing is that sepsis is responsible for about 1 in 3 deaths worldwide every year. Now, it's irrespective of whether or not the underlying cause is something like pneumonia, a surgical complication, or even just an infected wound. Sepsis is quite commonly what tips that otherwise a treatable infection into something deadly. So to bring this into context, what's happening in Australia? So more than about 84,000 people every year are hospitalised with sepsis, and about 12,000 of those individuals don't survive. And so that's more people dying every year from sepsis than what we see occurring from traffic accidents or from stroke. And this is quite profound because most people don't even know what sepsis is, despite the actual burden on the health system. Now, one of the other big problems with sepsis is it doesn't just end with discharge. Of those people who do survive, about half of them are left with some permanent form of disability. And this could be chronic fatigue, cognitive impairment, recurrent infections, or some type of post-traumatic stress or amputation. So sepsis isn't just life-threatening, it can fundamentally change your life after you've had it. Now, in terms of elevated risk, who do we normally see being at high risk of sepsis? Well, there's individuals over the age of 65, newborns and young children, people with chronic health conditions, so things like diabetes or kidney disease, anyone who's immunocompromised. Aboriginal and Torres Strait Islanders have a particularly disproportionately high burden, and pregnant women are also at high risk. Now, it's important to point out, though, that just because these individuals are at high risk of sepsis doesn't mean if you're fit and healthy, you're safe. Fit and healthy people do develop sepsis, and this can occur from normal infections because it's what happens when your immune system doesn't stay correctly under control. So what actually causes or triggers sepsis? Well, potentially any infection can lead to sepsis, but the bacteria I'm showing here are the most common causes. I've really just highlighted 6 key bacterial culprits here, and don't worry too much about the details. Really, it's just to highlight these are, we work on most of these organisms in my lab, and they'll have names that you may have heard before, things like Staph aureus or golden staph, and its drug-resistant variant, MRSA. That's one of the most common causes of hospital-acquired sepsis. Streptococcus pneumoniae, also known as the pneumococcus. Now, it commonly causes pneumonia and meningitis, as well as otitis media, which is an ear infection. And the fact that this organism, because of causing pneumonia, it's actually the most common cause of sepsis. E. coli, many of you will have heard of that organism. Now, this commonly causes urinary tract infections or gastrointestinal infections, and UTIs are actually the second most common cause of sepsis. We also see other organisms like Klebsiella pneumoniae, Streptococcus pyogenes or group A strep, as well as enterococci and its particularly concerning drug-resistant variant, vancomycin-resistant enterococci, also being common causes of sepsis, particularly in the context of hospital environments. So it's really, whilst these bacteria might have an array of confusing names, really the thing that's most concerning to those of us who are working on these organisms are the fact that we have drug resistance, in many cases, multi-drug resistant variants of most of them. We commonly call these superbugs. And this means they've evolved resistance to almost all of our powerful antibiotics that we would otherwise use to treat them. And so this really makes treating sepsis a real challenge if our primary treatment method, using antibiotics, no longer work very effectively. So how can this ordinary infection from one of these organisms obviously go on to cause a life-threatening emergency? Well, as I mentioned earlier, normally what happens is when your body encounters a bacterium organism, whether it's you've aspirated, breathed it into your lungs, whether you've got an infected cut, normally what happens is your immune system responds to that. It can sense the bacteria because they give themselves away. And what it does is it sends white blood cells and other types of phagocytic cells to those sites where the bacteria are present in order to try and capture them and kill them. Now, what happens as part of that is those immune cells release chemical signals, and those chemical signals trigger a process called inflammation. That's swelling that can occur within those tissues. Now, this is very important in the context of how your body wants to fight off these infections. That inflammation, when it occurs, what it's actually there to do is to cause blood vessels to dilate. That lets more immune cells to come to those sites of infection, and this is your body doing what it does in order to try and control infection. However, what happens in sepsis is that normal immune response spirals out of control. In sepsis, we undergo what's a process called dysregulation, where that normal immune response to infection, that inflammatory response, starts to spread throughout the body. It isn't contained at the site of infection. That becomes potentially systemic, spreading throughout your body. What happens is your blood vessels start to become leaky. Blood pressure starts to drop, and your immune system then continues to cause more damage because it's not able to be switched off. And this is essentially that friendly fire I was talking about before, really on a massive scale within your body. Now, what happens is that damage can lead to organ failure, with kidneys starting to shut down, lungs struggling to exchange oxygen, and the heart not being able to maintain blood pressure. The brain becomes confused, and really what happens is this is at the point where sepsis has gone from being a concern to really being a medical emergency. And really, this is an important statistic to point out, because every hour that you delay treatment where there's a risk of sepsis, it actually increases the risk of death by nearly 8%. And so that's why it's really important to recognize the signs of sepsis early on and seek appropriate treatment. So how can you recognize sepsis? And so this is really probably one of the most important points I can try and share with you today, because this is a real challenge. And the challenge is because sepsis quite often looks like just a normal infection to start with. And that really makes it tricky to tell when something might be escalating the wrong way. So there are 6 key signs to really keep an eye out for: high fever or very low body temperature. We have a very rapid heart rate. And so this is where it feels like even when you're sitting down or resting, your heart's racing. Fast and difficult breathing, particularly if you're having more than 22 breaths per minute. That's a really big red flag of potential risk of sepsis. Confusion and disorientation. So if you're really struggling to think or feeling unusually drowsy, this is one of the more common signs, particularly in individuals over the age of 65. Extreme pain or discomfort. So patients who've actually had sepsis often describe it as the worst illness they've ever had. And so if it feels more extreme than anything you've had before, there's a real risk here that something else might be occurring. And we often see in individuals who are at risk of sepsis, what we're seeing, particularly around their extremities, they quite often have a loss of or tissue or skin discoloration. So their skin can become pale or blotchy or even blue or grey. And that's a real clear sign that there's something going on, particularly around your blood pressure. So individually, any one of these symptoms might not be that alarming, but really in the context of sepsis, the thing to watch out for is the combination and the severity of these symptoms. If suddenly someone who's been unwell starts to develop many of these signs, if they seem sicker than they would normally be in responding to fighting off an infection, this should set off some alarm bells. This is where it's best to trust your gut that there might be a risk of sepsis and try and get some help, rather than risk, trying to wait and find out too late that something should have been done. So what should you do if you spot multiple signs here that indicate risk of sepsis? Well, there really are 3 important steps. And the first thing you can do is ask yourself that question: could it be sepsis? When you're following up with help, ask the nurse, ask the doctor, ask the paramedic, because you don't want to be embarrassed. There's nothing to be worried about being told no, it's not, but you need to keep asking that question to be sure that there isn't something here that we should be watching out for. This simple question of could it be sepsis is actually pivotal towards a program that's being run in New South Wales called the Sepsis Skill Programs. That's designed precisely to encourage people to be asking this question, both patients and doctors. In fact, this program's been working so well, this question being asked, the question of could it be sepsis, has actually led to much improved rates of detection of potential sepsis, and actually led to reduced mortality by sepsis by nearly 30% because of this recognition of these warning signs much earlier on. This really relates to step 2, which is call for help immediately. If you're worried that it could be sepsis, call 000 or go to the nearest emergency department in order to seek help. If you've got multiple red flags, don't wait at home to see if symptoms improve, because sepsis can move very fast. This is not one of those situations where leaving it to see how you feel in the morning is a good idea, because by that time it may be too late. And step 3, when you get to hospital, make sure you mention whether or not you've had any recent infections, any surgeries, any UTIs, anything that's unusual in terms of illnesses within the past few weeks that could have exposed you to an organism that's causing this sepsis response. Again, this is really about making sure the people who are doing the examination have all the information to try and reach a correct diagnosis as early and quickly as possible. So you've done all your good work, you've gone to hospital, it's being diagnosed as sepsis. What do we do? Well, there's really 3 key treatment pillars that I'll sort of mention today. And the first is really the most critical to success, and that's antibiotics. And giving individuals, when they come in, broad spectrum antibiotics, because at this point we want antibiotics going to be very effective against the broadest range of potential infectious organisms. we want to administer these in the first hour so they have as much time to work and try and get an infection under control as possible. So at this point, it's really about speed trumping precision when we're trying to give these broad spectrum antibiotics, because we don't actually have time to figure out what the causing for the infectious organism might be. We need to just try and get to the point of an effective treatment. The second key pillar of dealing with sepsis is fluid resuscitation. So here, patients are given volumes of intravenous fluids to try and maintain blood pressure and keep blood flowing to organs. And this is really important in order to try and support these patients, in conjunction with putting them onto this third pillar, which is supportive care. So this means intensive care monitoring. So drugs to help maintain blood pressure if the fluids aren't enough, mechanical ventilation for patients who aren't otherwise able to breathe for themselves, dialysis to avoid risk of kidney failure, and essentially keeping the patient alive with these supports long enough so that their immune system can be brought under control and this infection can be dealt with by the antibiotics. And so this really brings you back to that first key pillar. We rely on these antibiotics to really try and help control that infection, obviously in conjunction with the body's response, but really it's that key part of the antibiotics being the cornerstone of this intervention and how we need to treat. And so this brings us to really this big problem that's a real central part of my work, which is trying to address this antibiotic resistance crisis. And so the antibiotic resistance crisis, this problem is really about the fact that bacteria are evolving resistance to our antibiotics much faster than we can develop new ones. In fact, superbugs, which are out there, have rendered many of our most powerful treatments essentially useless. In 2019, antimicrobial resistance was associated with nearly 5 million deaths worldwide. Now, it's important to point out that these superbugs, these organisms causing these untreatable infections, aren't exotic or rare organisms. These are the same bacteria that cause pneumonia and urinary tract infections and wound infections that lead to sepsis. And the problem here is that those resistant organisms are now the ones causing infection, and that means our first-line broad-spectrum antibiotics now don't work. And so we're left scrambling for alternatives while that ticking clock about mortality is moving away from us in the context of effectively dealing with sepsis. Now, the big gap that we have as a society is the fact that the pharmaceutical industry has largely walked away from antibiotic development. It's simply not profitable to make new antibiotics compared to making drugs for treating chronic conditions that patients need to take for the whole of their lives, or other types of new therapies like weight loss drugs. These are far more profitable than making antibiotics that someone might only need to take for a few days before coming off that therapy. And so this antibiotic development pipeline is drying up precisely at the point where we need it most. And so we really need new approaches to treatments, not just new antibiotics, to try and deal with these resistant organisms. That's where research back in the labs and at universities has really had to sort of step in to try and come up with new strategies to try and fight sepsis. So what are the types of things that we're seeing? Things like precision immunotherapy to try and help deal with those infections by tuning the immune response, rapid diagnostics to help us try and identify high-risk cases of sepsis much faster, identifying or developing new molecular signatures to try and predict when a high-risk sepsis might be occurring and what the right treatment approach might be. But the one I really want to talk about today is our work on breaking antibiotic resistance. So in my lab, this is something we've been spending a lot of time working on, and we've been trying to find ways to defeat how infectious organisms are able to sort of resist antibiotics. And so one of the things that we discovered is that during infection, one of the chemicals, one of the elements that the body moves into sites of infection is zinc. And something else we discovered is that when bacteria are overloaded with zinc, it disrupts their ability to resist antibiotic therapies. Now, the problem we had was that bacteria can pump zinc out much faster than our bodies can actually get it into them. And so to try and solve this issue, we discovered a molecule or identified a molecule called PBT2, this one here. So, using PBT2, what we were able to find out is we could use it to transport zinc that your body is putting into these environments, the lungs and in the blood, into the bacteria much faster than they can pump it out. And so when the PBT2 loads them up with zinc, this disrupts the bacteria's ability to resist antibiotics, and it means that now we have the capacity to use those frontline antibiotics once again to try and treat the infection. So essentially, we discovered a way to harness the body's own immune response to infection and make it even more effective against the invading organism. So what is PBT2? I'm not going to dwell on the details. Essentially, it was a molecule that was originally designed for another use, treating neurodegenerative diseases like Huntington's and Alzheimer's, that was associated with disrupted metal levels in the brain. That ultimately didn't pan out. However, there were a lot of clinical trials that were run. They went all the way to phase 2, showing that this molecule was safe for use in people. And so we were able to take that molecule and repurpose it for a new application because we could discover that this ability of PBD2 to push zinc into the bacteria was something we could take advantage of in order to make them susceptible to antibiotics. And so really our mechanism with PBT2 is that it takes that host zinc, pushes it into the bacteria. This disrupts multiple cellular processes. And the key one that we're really interested in is that breakage of antibiotic resistance. So we're able to rescue the efficacy of antibiotics and make them work first time, every time with PBT2. So where are we at in developing this molecule? So we've been able to break antibiotic resistance in almost all the bacteria that cause sepsis, including MRSA, vancomycin-resistant enterococci, group A strep, as well as strep pneumoniae. Importantly, in our work to date, what we've also found, or we've been able to show, is that bacteria can't develop resistance to PBT2 treatment. And this is really important because we don't just want to provide them with an opportunity to develop a new type of resistance because of the way bacteria need zinc for viability, but too much disrupts a range of essential processes. They can't just evolve their way out of being able to resist this treatment. We've proven this works in animal models, so that's really what we've been doing over the last few years, is showing efficacy in treating in vivo models, so in animals, that we can clear sepsis caused by drug-resistant organisms and pneumonia caused by drug-resistant organisms using PBD2 plus antibiotic combinations against those drug-resistant bacteria. And so now we're trying to progress this further, as well as expanding the scope of opportunities to try and progress PBD2 into other conditions like UTIs. So bringing this back to sepsis, why does this really matter? Well, as I mentioned, when a patient develops sepsis caused by an antibiotic-resistant organism, our standard treatments fail, and it becomes a race against time to find the right treatment tool. With PBD2, we've actually got an opportunity to try and make those bacteria susceptible again to those frontline broad-spectrum antibiotics. And so really our goal is to try and advance PBD2 to the point where it can be administered alongside those frontline antibiotics when patients need them most in that first hour. So I mentioned there's lots of key advantages to our molecule. It's already been shown to be safe in humans. It can restore the efficacy of frontline antibiotics that are already in the market and already safe. And it's got that resistance-proof design that we've shown in multiple studies. This is sort of our roadmap, and I don't really need you to be worried about the details of it. It's just really to highlight where we are, which is really in that lead optimization phase and hopefully getting into preclinical studies very soon. The key point here is this is actually quite a fast timeline. This is quite a fast timeline in terms of the development, and this is really because we're able to take advantage of the fact that we're repurposing a molecule, and so this means we can expedite it through some of these stages where we don't need to worry about key safety concerns that might affect a new antibiotic or a new drug. So really I'm trying to move fast now. Funding being our main challenge, as you're probably aware, that's a real big issue in the terms of the research sector. Obviously, so we can try and progress these key stages. So let me leave you with 5 key messages. Sepsis is an important medical emergency, and it's one that you should be aware of. Anyone can develop sepsis from any infection, and so being aware of what those warning signs to look out for are very important. And then also being ready to ask that question of could it be sepsis, because that can save lives. Antibiotic resistance makes sepsis harder to treat. And so this is really why we need to start developing new therapeutics as well as other approaches to try and come up with ways to defeat antibiotic-resistant superbugs that cause sepsis. So look, thank you for your time and attention today. This is my team. We're working to make a real difference in overcoming antibiotic resistance in diseases like sepsis and pneumonia. And with that, I need to acknowledge our funders who've supported us today, and I'm very happy to take any questions.
Thanks very much, Chris. Is there any questions for Chris?
No, I've just thought loud. I'm a pharmacologist from Monash, so I'm very interested in the drug side of your work. And just wondered about delivery of this drug. Is it a small molecule, or is it in terms of be delivering it directly into the lungs if someone's got a lung infection, or is it a systemic?
So it's a small molecule drug. We're able to deliver it orally, which is really great for outpatient treatment. And so we're working through all the trying to understand just biodistribution into the lungs at the moment. So obviously in the process of doing those PK scoping studies with our preparation. The goal here would be getting it to the right concentration at the right time of the antibiotics to be effective. Happy to discuss that further because that's a real key component of our program. But yes. For the nature of the development program, we establish the infection before and then treat afterwards.
Thanks. With the widespread uptake of the SGLT2s and GLP-1s, are we seeing what was reported in some of the trials, increase in Fournier's gangrene?
I don't have a good answer to that question. We'll need to talk to you about it later.
We're often told that one of the potential advantages of AI is in the field of accelerating the rate at which you can go through to clinical, through the clinical trial period. 5 years seems quite encouraging, but is there a potential that AI could bring that forward?
I haven't heard anything from the sector around from the industry side in terms of the development pathways where any of the kind of work that we're doing around the preclinical animal models and the toxicology that could be expedited by AI. That's a nice idea in the future. I've heard the promise of it, but I haven't seen anything, and our industry colleagues haven't suggested there are ways to skip past that. It's really I guess, particularly when we're thinking about human trials and developing molecules that will go into humans, there still has to be a really high bar around safety. And, all our animal models are imperfect in various different ways, but they're still, in many ways, the gold standard for what we've got right now. And it could change in the future, but I guess it depends on what data the AI is learning from and what we're providing with to make those predictions.
Yeah. Very exciting work. I wish you well.
Thank you.
Any more for any more? No?
Well, Chris, thank you very much for your very informative presentation today. And I'm sure that if we all spread the word, hopefully it will save more lives in the future, because I think it is a very serious disease that we need to take more attention to. On behalf of Rotary Melbourne, I'd like to present you with a pair of Rotary Melbourne socks, which are made, they're actually made here in Melbourne, 100% Australian. So thank you very much again for your speech.
Thank you very much.
I'd like to thank everybody for attending the luncheon today. Thanks also to our MC, past President Bob Glindeman, and past President Robert Fisher for today's reflection, and our setup and reception team for their efforts. A reminder that next week's meeting is right here at lunch at number 35, and our guest speaker will be Walter Lee, AFL Executive General Manager, Strategy, Data and Analytics, Investments. Please look to the bulletin or the website for further information.